Greetings from Washington, D.C. I'm Peter Thomas, the General Counsel of NAAOP, the National Association for the Advancement of Orthotics and Prosthetics. Following up from the all-member webinar that NAAOP held on April 17, 2013, we wanted to answer a few questions that we received from our members in follow-up to that material. That webinar involved physician documentation and many of the audits that have occurred as a result of the Dear Physician letters sent by the DMAC medical directors and to all MACs to physicians across the Medicare program in August of 2011, talking about what's required in terms of physician documentation for O&P claims. There's a few things that we wanted to touch base on and to make sure that you are aware of. The first is the number of additional documentation requests that CMS can request from you as an O&P practitioner and O&P provider. It's changed in the recent past. Within the last several weeks, CMS has tried to accommodate the O&P field by making a specific rule for O&P practitioners. Right now, the rule for all DMEPOS suppliers is 250 claims every 45-day period can be requested from DME suppliers for review by the different Medicare administrative contractors. That's a big number. There is a new number for O&P providers. If the O&P practitioner in the claim that is submitted has any one of the number 50 codes, which basically ties back to a specialty O&P code, then in fact the limit on ADRs is 10 patient files per 45-day period. That's a major reduction, and it's something that's very encouraging. We don't know exactly how many O&P practitioners or businesses that will actually impact in a meaningful way, but it's certainly a movement in the right direction. Next issue involves pre-discharge delivery from an inpatient facility. In other words, there is something known as the 2-day rule, and if you provide O&P care to an inpatient in a hospital or in a Part A covered skilled nursing facility, there is a rule that says that Medicare Part B can be billed for that care if the primary use of that orthotic or prosthetic device is in the patient's home or, shall I say, outside of an institution. If the primary use is for the patient in the inpatient setting, then the hospital will be billed and should pay that claim. But ultimately, if the use is for outside of the institution, the practitioner can deliver the O&P care in the hospital within 2 days of discharge and then go ahead and bill the Part B program. There's been no change to that rule. There was a question on our webinar as to whether the rule had been changed. In fact, it still is the same rule as it always has been. Next issue involves prepayment review. There was a question as to whether CMS had the ability to just put anyone on prepayment review that they wanted. Well, under the RAC program, the Recovery Audit Program, RACs can only put providers on prepayment review under a demonstration program. And right now that demonstration program does not apply to O&P practitioners, only applies to claims involving therapy reimbursement. However, under the MACs, the Medicare Administrative Contractors, including the DME MACs, they are empowered. They do have the authority to put practitioners or to put O&P businesses on prepayment review. But they're supposed to demonstrate that there is a high or a sustained error rate prior to doing so. So if you're put on prepayment review and you've never had claims denied and you don't have a high error rate, then you should definitely challenge being put on prepayment review. Having said that, prepayment review is not as scary as some would think. Prepayment review offers the provider the opportunity to perfect the claim and to submit clean claims in order to get reimbursed by Medicare. And so if you are put on prepayment review, the best advice is to focus on the documentation and do everything in your power to submit clean claims. And if you can do that, you will be taken off of prepayment review relatively quickly. Finally, the issue about RACs was discussed and what issues they can delve into and what they are not permitted to. The fact is that CMS has even a separate contractor devoted to selecting what issues RACs can and cannot pursue. And in fact, each RAC in all of the 4 regions is permitted to review claims involving O&P services. The full listing and specific list of approved services is on the NAAOP website at www.naaop.org, and we encourage you to consult that website for that information. Of course, on the larger issue of physician documentation, NAAOP and the entire O&P community, all of the Washington-based associations, are actively working to bring some reasonableness to this process and to figure out a way that O&P practitioners are not in the crosshairs, frankly, between the physician's documentation failing to meet medical necessity guidelines and perfecting claims and submitting good claims. And so we'll continue to do all we can to try to resolve that process and to improve this situation for the O&P community. Thanks so much.